maintenance of inhibin, which is inhibin, which is very important in the menstrual cycle, ghrelin and leptin, which is very important in um, the managers of obesity. So these are produced from the gastrointestinal tract and have other roles other than the tissues of origin. Okay, so when we talk about endocrinology, we talk about these three things. So the three things that we talk about are hormone deficiency, hormone excess, and hormone resistance. Okay, so these are the different causes of endocrine dysfunction. Okay, so we have hyperfunction. If we say hyperfunction, it means it comes either from a neoplastic origin, an autoimmune origin, or it may be iatrogenic, or it may be infectious, or it may be due to activating receptor mutations. So if you are considering a neoplastic origin for your endocrine dysfunction, you need to think about whether it is benign, malignant, or ectopic, and therefore the challenge is to look for where the problem is. Is it in the peripheral gland itself? Is it in the hypothalamus? Or is it in the upper centers? So maybe benign, like for example, in pituitary adenoma, in in hyperparathyroidism, or in pheochromocytoma. Maybe malignant, like for example in adrenal cancers or in medullary thyroid cancer. It may be ectopic, like what happens in ectopic ACTH secretion brought about by tumors, or in SIADH, or it may be due to a lot of endocrine problems like multiple endocrine neoplasia, maybe autoimmune, like in Graves' disease or in type 1 diabetes, maybe iatrogenic, like in Cushing syndrome, or maybe infectious, or maybe due to activating receptor mutations, which we will talk about later. So, aside from hyperfunction, it may be due to hypofunction. And the causes of hypofunction are almost the same as in hyperfunction. So again, it may be autoimmune, or it may be iatrogenic, like in radiation-induced hypopituitarism or hypothyroidism. It may be infectious, like in adrenal insufficiency, or it may be due to hormone mutations in the receptors or enzymatic defects, or it may be due to developmental defects or nutritional deficiencies, or due to hemorrhage or infarction, like in Sheehan syndrome, or it may be due to hormone resistance. So when you talk about hormone resistance, this is usually due to receptor mutations in the membrane, or in the nuclear receptors, or in the signaling pathway mutations, which again I will talk about in a few minutes. So actually, the approach to a patient with endocrine disorder is actually no standard endocrine history or physical examination. You need to evaluate your patients on the context of presenting signs and symptoms, on the review of systems, and on the family history and social history, and of course, the exposure to medications. Therefore, your clinical judgment is very important because based on the knowledge of the disease prevalence and the pathophysiology, this will help you to decide the diagnostic workup which is required for your patient. And for the laboratory testing, this plays a very important role in endocrinology because it allows quantitative assessment of hormone levels and, of course, the dynamics. Hormone measurement is simple right now because it involves uh, radioimmunoassay laboratories, and it is the very most important because this uses two labeled antibodies to increase the specificity and sensitivity of the test and to detect quantitative measurements of steady state and dynamic changes in hormone concentration. We need hormone measurements if you want to assess a patient with endocrine problems, because hormone measurements are specific and sensitive enough because it can detect hormone levels up to the picomolar or nanomolar level, and this distinguishes structurally related proteins. Plasma or serum samples, urine samples, are the ones which we use because these hormones are secreted in a pulsatile fashion, and one single blood test might not be reflective of what your patient has. So you need to get 24-hour urinary sample, or you need to get a plasma sample or a serum sample. After laboratory testing, the next challenge is how to interpret the findings of sound clinical judgment. That is the reason why we have basic tests. If the test is abnormal, you go on to use hormone pairs because you need to know the expected result in these hormone pairs in order to increase the sensitivity and specificity of your test. And then you move on to dynamic testing if both of these tests are equivocal. So dynamic testing is used to separate normal from abnormal results. So this is the challenge on how to interpret especially these tests that you request for. These are the tests that we usually do in the more common endocrine diseases involves goiter, obesity, osteoporosis, and diabetes. So for obesity, this is the approximate prevalence in adults, and you do the screening test by calculating for your body mass index, measuring your waist circumference and waist ratio, and you need to exclude secondary or hormonal causes of obesity. And of course, we need to consider comorbid complications. For type 2 diabetes, the prevalence is already increasing in adults as of now. Since beginning at the age 35, it is now at age 35, not 45, every 3 years or earlier in high risk groups. And if the fasting blood glucose is more than or equal to 126, or the random plasma glucose is more than or equal to 200 milligrams per deciliter, then that gives you the diagnosis of type 2 diabetes. An elevated HbA1c of more than or equal to 6.5% in an NGSP certified laboratory. These are the things that you need to see to diagnose diabetes. Consider comorbid complications. Sorry, you need to consider comorbid complications in type 2 diabetes. And therefore, if you have a patient with type 2 diabetes, and this patient has been diabetic for a long time, or even if the patient is newly diagnosed diabetic, it's like you have to do a full workup. It's like doing a full executive workup because diabetes has complications in all parts of the body. So you need to do an executive checkup in order to know the status of your patient, especially the existing comorbid complications that your patient has. In hyperlipidemia, you just need to do a lipid profile. And in lipid profile, you need to do a complete lipid profile. So it's not just total cholesterol, but you need to do the full profile. And then in hypothyroidism and in hyperthyroidism, these are your prevalences. And usually you do an FT4 and TSH test, and you screen women after age 35 every 5 years thereafter. And in thyroid nodules and mutation, that is the time that you do an ultrasound test and a fine needle aspiration biopsy. And as for osteoporosis, there is a calculator for osteoporosis in order to see your risk for osteoporosis. And you do the bone mineral density test for patients more than 65 years old and hyperparathyroidism. Usually do serum calcium, a parathyroid hormone test if calcium is elevated, and assess for other comorbid conditions. So if you're going to see here in this chart or in this table, the prevalence that you see is decreasing. So most common is obesity. And then type 2 diabetes and thyroid diseases, then osteoporosis, and the prevalence of hyperparathyroidism is now increasing. So we now move on to the mechanisms of hormone action. So if you talk about hormones, they're actually classified into five. So amino acid derivatives, protein hormones, small neuropeptides in large protein, steroid hormones, and vitamin D derivatives. So in vitamin D derivatives, that is the action of vitamin D and vitamin A, steroid hormones are usually coming from the adrenals, so includes cortisol and other hormones. These are just examples. The amino acid derivatives are dopamine, catecholamines, and thyroid hormones, and protein hormones are usually those that come from the pituitary gland. Okay? So the reason that you classify hormones into this and receptor families because that is where you derive the action of these hormones. So for amino acid derivatives, usually they have cellular receptors except thyroid hormone because thyroid hormone has a clear receptor. So protein hormones, small and large protein hormones, again, they have cellular receptors, and steroid hormones and vitamins usually have nuclear receptors. So these are the different signaling pathways and membrane receptor families. So they act on cellular receptors. These are cellular receptors. So usually we have what we call the G protein coupled 7 membrane receptors, and this includes the GS alpha, then adenylate cyclase system, the calcium channels, the G inhibitor alpha, and the TRH and GRH, which acts on different signaling pathways inside the body. For the tyrosine kinase receptors, the most common example of tyrosine kinase receptor is insulin. And for cytokine receptors, this includes the growth hormone, and for serine kinases, this includes activin. These are the membrane signaling receptor families, and you can see the different examples at the top, and then you can see the signaling pathways in the center. So these are the different membrane receptors. So to go in each one of these, for example, the G coupled 7 membrane G protein coupled 7 transmembrane receptors. So this is an example of the G membrane transmembrane receptors. So this passes the membrane 7 times, and that is why well, it is said to be 7 membranes. And in the off state, the GDP is still connected to the G alpha, the gamma, and the beta. But once the ligand is connected or ligand attaches to the membrane protein, the GDP now dissociates from this complex, leaving the GTP and the G alpha, leading to the different signaling pathways downstream. So using this membrane receptor example or model, you can now activate four pathways. The ion channels, which is inhibition of the cyclic AMP leading to cell motility. It may increase cyclic AMP. It may increase diacylglycerol and inositol phosphate 3 leading to cell proliferation. And it may also lead to cancer progression and metastasis by activating the Rho protein. And so you will see here that any problem in the signaling pathway can actually be the basis or pathology of developing cancer. And it is also the target of different drugs in order to arrest both mobility, cell proliferation, or cancer progression and metastasis. So this is a detailed stepwise pathway for the seven transmembrane protein. So as I said, the GPCRs undergo conformational change upon ligand binding, wherein the GDP dissociates from the complex and it is exchanged by G alpha subunit GDP for GTP. Once the GTP attaches to the alpha subunit, it now activates the adenylyl cyclase that converts the ATP to cyclic AMP, and this elevated cyclic AMP levels then activate the protein kinase A cytokine, protein kinase A, and this now activates the protein kinase A phosphorylates and several enzymes and transcription factors wherein causes gene expression that mediates cell growth and differentiation. I know that you already tackled this topic in biochemistry. So it's just an example, or this is just a review of your biochemistry, and this is how you apply now what you know in biochemistry, because it is not just it is just not a discussion of these pathways, but it is really what happens inside your body in order for you to understand the mechanisms or pathophysiology of different diseases. So this is actually what you do in molecular biology. So this is another pathway. Okay, so this is the cytokine pathway wherein your messenger now attaches to the receptor. And again, I'm sorry, this is another. So the messenger attaches to the to the receptor, and then again it stimulates this complex. And when the GTP alpha is replaced by GDP alpha, the other ligand which is stimulated here, it is adenylate cyclase, but here it is protein kinase C, which is stimulated by the following pathways. And the end result of this is the activation of your palmodulin and protein kinase C, again, due to the calcium second messenger, which comes from the lumen of the endoplasmic reticulum, which will lead again to contraction and cell which leads again to cell metabolism and transport. Now, this is different with the insulin signaling pathway, the tyrosine kinase pathway. So in the insulin signaling pathway, you can see that the insulin receptor has an alpha and beta chain. So in the alpha and beta chain, the beta subunit of the insulin receptor is activated by tyrosine kinase phosphorylating tyrosine in beta subunit. So once the insulin attaches to the receptor, the tyrosine kinases are activated, which leads to the activation of insulin receptor substrate 1, and this will lead to a cascade of responses leading to the activation of phosphoinositol kinase 3 or phosphoinositol biphosphate, and leading to the final, which is the activation of the protein kinase B. And because of the activation of that protein kinase B, it will now lead to the increase in GLUT4, and GLUT4 is the channel through which the glucose now enter the cell. So that is how glucose enters the cell, through these channels. There is a GLUT1, GLUT2, GLUT3, GLUT. This enters now, this is the door through which glucose enters the cell. And by activating activates at GLUT4 in order for glucose to enter the cell. the same. And problems in this insulin signaling pathway is said to be the reason for type 2 diabetes. And cytokine signaling pathway, it activates the JAK pathway. And by activating the JAK pathway, leads to the transcription of different cells. And this is also the mechanism by which some cancers act. And some new cancer agents now target this JAK pathway in order to arrest the growth of cancer cells. For nuclear receptors, we have a lot of nuclear receptors. We have the type 1 and the type 2. So we have the homodimer steroid receptors, the heterodimer steroid receptors, and the orphan receptors. Here, you activate a ligand, co-activator binding, and in the other, the heterodyne receptors, the ligand dissociates co-repressors and induces co-activator binding. And for orphan receptors, this is a constitutive activator or repressor binding. So this is how it works for intracellular receptors. So for intracellular receptors, again, as I said, there is a type 1 and a type 2 intracellular receptor. In type 1, the receptor is in the cytoplasm and then it goes to the nucleus. In type 2, there is an intracellular receptor. There is no more intracellular cytoplasmic receptor. Okay, so in the type 1, this is the example for estrogen receptor and progesterone receptor. For type 2, the example is retinoic acid receptor and thyroid receptor. So we will go to that later in our discussion for thyroid diseases. So intracellular receptors are a family of ligand activated transcription factors, and these are activated by steroid hormones and other lipid volume signals such as retinoic acid. The main uh, the main exception to this rule is thyroid receptor, because the thyroid receptor is a protein protein type of hormone. So this is how it works with type 1 nuclear receptor. As I said, for the type 1 nuclear receptor, there is an intracellular receptor. So once your ligand enters, like for example estrogen, it first binds to a cellular receptor, which is the NR-HSP complex. And the step 2 is dimerization of the receptor complex, wherein the NR now separates from the HSP complex, and that NR now enters the nucleus, leading to the binding of the NR dimer to DNA, leading to a change in cell function. Whereas in nuclear 2, there is no more cytoplasmic receptor. The ligand goes directly to the nucleus where it causes either where it attaches to the co-repressor, and by attaching to the co-repressor gene, it now activates it, or by activating the co-activator directly. So the ligand binds to the receptor, causes the dissociation of the co-receptor. It recruits co-activator proteins that leads to the gene expression and leads to transcription and changes in different pathways. Okay, so hormone synthesis and processing is different for protein receptors, amino acid receptors, and steroid hormone receptors. So for amino acid receptors, or I'm sorry, for amino acid derivatives, they of course are derived from amino acids. Like for example, thyroid hormone, then norepinephrine, epinephrine. These are derived from amino acids, and they are subsequently cleaved in a series of enzymatic steps to produce the final hormone. For protein hormones, either the small and large hormones, they usually come from a larger protein. And this follows the classic pathway of gene expression, like transcription, then mRNA, then this goes to protein post-translational protein processing, intracellular sorting, and membrane integration or secretion. Large precursor proteins are subsequently lysed or undergo proteolytic degradation to give you the final protein. So, uh, proteins that are proteologically processed to produce an active biological hormone. So, it occurs within the endoplasmic reticulum. While steroid hormones or vitamins, this is the modification of cholesterol and the specific transcription factors such as the steroidogenic factor 1 acts on acts in conjunction with signals from trophic hormones leading to the final hormone, which comes from multiple regulated enzymatic steps, which will lead to the final hormone. So usually these are the vitamins, steroid hormones like cortisol, aldosterone. These are the ones which undergo this final test. Okay, so once they are formed or once they are synthesized, it's now ready to be secreted and transported to the different parts of the body where they need it. So for amino acid derivatives, they usually undergo exocytosis of secretory granules in response to a signal. So once a signal comes, they usually undergo exocytosis to release the hormones. For the protein hormones, the hormone level is determined the rate of secretion and the half-life. And exocytosis of secretory granules is in response to a signal or neuropeptide. So it is only released when there is a releasing factor or a signal. And the hormone transport and degradation dictates the rapidity with which the hormone signal decays. So the faster the transport or degradation, the faster the decay of the hormone. And that is the reason why some hormones only are present in your body for a very short time. The steroid hormone secretory rate of a hormone is aligned with its synthesis. So they diffuse into the circulation as they are synthesized, and because they are steroid hormones, you need binding proteins for them to be transported to where they need the hormone is needed. Hormones are regulated by the feedback mechanism. Feedback control is a fundamental process in endocrine systems. It is especially used for the hypothalamic pituitary axis. So this maintains hormone concentrations in a very relatively low range. So for example, you know this very well. You have the hypothalamic thyroid, pituitary thyroid axis. You have the hypothalamic pituitary adrenal axis. You have the hypothalamic pituitary gonadal axis. So these are the peripheral hormones which are affected by this hypothalamic pituitary feedback control. So it just means that the concentrations of these hormones in the periphery feeds back these signals to the periphery or to the pituitary and the hypothalamus, uh, giving these two organs an idea of the concentration of these hormones in your periphery. So, for example, for thyroid hormone, if the levels of thyroid hormone in the periphery or in the blood is high, then this signal is sent to the pituitary and the hypothalamus, and the effect is to decrease the secretion in these two organs in order for the concentration for the thyroid hormones not to be elevated. And consequently or conversely, In hypothyroidism, the pituitary and the hypothalamus senses whether the concentration of thyroid hormone in the periphery is low. And if it is low, then they need to stimulate this hormone in order for the balance to be restored. And that is how the hormone regulation, feedback hormone regulation works. In paracrine regulation, this refers to factors released by one cell that acts on the adjacent cell in the same tissue. For example, somatostatin on insulin or glucagon in the pancreas. So this is very important, especially in recent studies right now or recent discoveries right now. For example, the GLP, GIP, and the GLP hormones, which acts in a paracrine fashion on the alpha and beta cells in the pancreas. So, autocrine regulation describes the action of factor on the same cell from which it is produced. And example is IGF-1 acts on many cells that produce it, including chondrocytes, the breast, epithelium, and gonadal cells. This feedback regulatory system described are superimposed on hormonal rhythms that are used for adaptation to the environment. For example, the menstrual cycle, which is every 28 days, the circadian cycle, which is every 24 hours, and pulsatile rhythm, which are usually occurring in the pituitary. And it is very important in decision making as to the type of diagnostic test to request for or in the interpretation of the results. So we move on to the function of the hormones. These are the function of the hormones, particularly growth and differentiation. And for growth and differentiation, the hormones involved are growth hormone, thyroid hormone, steroid hormones, and sex hormones. And this is superimposed on the effects of malnutrition and chronic illness on growth or genetic abnormalities affecting the epiphyseal growth plates. And therefore, if you have a patient with growth problems or short stature, you need to look into the status of these hormones: growth hormone, thyroid hormones, steroid hormones, and sex hormones. Now, the other function of the hormone is on the maintenance of homeostasis. For many hormones, in addition to its own direct effects, parathyroid hormone regulates calcium and phosphorus, control the vascular volume and serum electrolytes, and insulin maintains euglycemia in the fed and fasted states. Reproduction is also one of the function of hormones because not only it is not only responsible for sex determination during fetal development, but it is also responsible for sexual maturation during lactation and for the cessation of reproductive capability at menopause. So, in summary, the scope of endocrinology, you cannot define endocrinology along strict lines because these hormones interact with other systems of the body. There is no standard approach to endocrine diseases. It is based on a good clinical judgment, existing prevalence of diseases, the pathophysiology, and proper interpretation of selected laboratory examinations. For the pathologic mechanisms of disease, you need to look for only three pathophysiologic mechanisms. Is it a hormone excess? Is it a hormone deficiency? Or is it a hormone resistance? Now, once you've established that, you need to know the reason for these pathophysiologic mechanisms? Is it because of a tumor? Is it because of autoimmune problem? Is it because of the absence of a gland? Is it because of infection? Or is it because of autoimmune problems? And the mechanism of disease is based on the classification of hormones. Mechanisms of hormone regulation, negative feedback mechanism is the main hormone regulation, but other forms of regulation are also present. Infant function is basically based on homeostasis, growth, reproduction. So that is the final slide for the first set. Let us now move on to the anterior pituitary hormones. Do you have any questions? Do you have any questions?
None, doctor.
Sure? All clear or all fuzzy? So I'll leave first and then I'll connect later, okay?
Okay, doctor.
Hello, can you hear me? I'm back. Hello?
Yes, doctor.
Okay, so I'll continue with my lecture. Can you see my screen?
Yes, doctor. Can you make it in the presenter's view, doc?
Yes. Wait. Okay, can you see my screen? Can you hear me?
Yes, doctor.
Okay, so we'll now proceed to the diseases of the anterior pituitary
Doc,
gland.
can you make it in the presenter's view, doc?
Sorry, see that in the presenter's view. So can you
No.
see my whole screen?
Yes, doctor. Yes, doctor.
Okay. Okay, so for the diseases of the anterior pituitary gland, so we have the pituitary, the peripheral glands. So this is actually the course outline that we are going through. So first we go to the anatomy of the pituitary gland. So the pituitary is oval, bean shaped. It is bilaterally symmetrical, and the weight of this gland is only about zero point 0.4 to zero point 0.8 with an average weight of zero point 0.6 grams, and it is actually very small. It is only about 9 by 13 by 8 millimeters, and therefore any size above this is already it's already enlarged. So it is composed of two lobes. It is composed of the denohypophysis and the posterior lobe, or the neurohypophysis. And this is the anatomy of the parapituitary area. So in the anatomy of the parapituitary area, you can see the gray portion, that is the area of the pituitary gland, and you have the superior, inferior, and lateral limits of this parapituitary area. Superiorly, you can see the optic chiasm. I'm sorry, you can see the diaphragma cella, and then above that you can see the optic chiasm and the optic tracts, and below you can see the sphenoid sinus in the inferior part of this parapituitary area, and laterally you can find you can find the sphenoid sinus, and you can also see the different cranial nerves. Cranial nerve 3, 4, 5, and 6, and the fifth cranial nerves. And therefore, the presentation of anything inside that pituitary gland is due to compression of these very important structures. For the blood supply of the anterior pituitary gland is the hypothalamic pituitary portal plexus. And this hypothalamic pituitary portal plexus comes from the superior hypophyseal arteries in 70 to 90%. And 10 to 30% of this hypothalamic pituitary portal plexus comes from the short portal vessels that originates from the inferior hypophyseal arteries, which supplies the distal portion of the hypophyseal stalk and the posterior lobe. Why is it important to know about this blood supply? because it is through this blood supply that the hormones from from the hypothalamus goes to the anterior pituitary gland, and it is how the hypothalamus exerts its control over the anterior pituitary gland. So we also have the posterior pituitary gland, which is supplied mainly by your inferior hypophyseal arteries. You already know this. For the venous drainage, it is through the sphenoid sinus to the jugular veins, and the innervation of the posterior lobe via the hypophyseal stalk is coming from the supraoptical hypophyseal tracts, from the supraoptic paraventricular nuclei to magnocellular nuclei, and from the anterior hypothalamus, and also it is from the tubero-hypophyseal tracts, which is coming from the central and posterior hypothalamus. Embryologically, the pituitary unit comes from the mesoderm and the oral ectoderm. So from the mesoderm, there is an invagination of the infundibular process leading to the formation of the posterior pituitary. Whereas in the oral ectoderm, it comes from the Thoracus pouch from the tongue, ectoderm of the tongue, and this causes migration from the area of the tongue towards the posterior pituitary, forming the anterior pituitary gland. So these are mesoderm and oral ectoderm. So what composes your pituitary gland? The new nomenclature recognizes five cell types. We have the lactotrophs, somatotrophs, gonadotrophs, luteinizing hormone, and follicle stimulating hormone, which forms your luteinizing hormone and follicle stimulating hormone, the thyrotrophs, which forms your thyroid stimulating hormone, corticotrophs, which forms your adrenocorticotropic hormone. And these are the different anterior pituitary hormone cells and their expression and regulation. On the left, you can see the different cell types. Sorry, on the top, you can see the different cell types and the factors, like, for example, tissue specific transcription factor, which leads to the formation of these cells. So, PROP1 and PIT1 is responsible for the formation of somatotrophs and lactotrophs, whereas the addition of thyroid embryologic factor or TEF leads to the formation of the thyrotrophs. The formation of DAX and SF1 leads to the gonadotrophs, and all of these transcription factors will lead to the development of these different cells, such that in 8 weeks you see now the appearance of these cells. By 8 weeks in the fetus, by 6 weeks, the earliest is the corticotrophs, and then followed by the growth hormone, then followed by lactotrophs, thyrotrophs, and gonadotrophs. Why is this important? Because, for example, in a patient with hypothyroidism, you do not expect with the fetus to form thyroid hormone during the first trimester, and therefore it is very important for you to control the thyroid hormones, because the thyroid hormones going to the fetus is coming only from the mother. Okay, that is one of the importance of knowing this fetal appearance. Now, these are the different hormones that it produces. For the corticotrophs, it is important to know that the hormone that is produced is the proopiomelanocortin, and the proopiomelanocortin through different splicing and therefore leading to the main hormone. Okay, so the chromosome locus is also located here, and the type of protein, it is mostly a glycoprotein, and the enzyme that inhibits it. So these are the different anterior pituitary hormones and the target glands to which they act on. Okay, so the trophic effects, of course, for the somatotrophs, for particularly growth hormone and prolactin, is responsible for IGF-1 production, growth induction, and insulin antagonist. specific to insulin, lactotrophs mainly for milk production, particularly that is prolactin. For thyrotropes, of course, it's the formation, the end effect is the formation of thyroid hormones, gonadotropes for sex steroid production, and for corticosteroids for steroid production. It's very important for you to know the staining because in histopathologic assessment, there will be a staining in order for you to know what hormones you are dealing with. The somatotrophs, growth hormone, lactotrophs, prolactin are both acidophilic. Only prolactin is chromophobic, while thyrotropes, gonadotropes, and corticotropes are all basophilic. And the amount and the location is also very important. You can see here that in the anterior pituitary gland, around 15 to 20% somatotrophs, I'm sorry, 50%, mostly growth hormone. Now, 15 to 20% is composed of your lactotrophs and corticotrophs, and the least is thyrotropes. Now, it's important to know the location. You can see that the gonadotrophs and the somatotrophs are laterally located, and the lactotrophs, prolactin, are posterolaterally located. And what is in the middle is thyroid and steroid corticotrophs. And this is very, very important because any compression on the pituitary gland leads to the conservation of the life threatening hormones, thyrotropes and corticotrophs. And therefore, if you have a tumor there, the last to be knocked out are the thyrotropes and the corticotrophs. And you need to look for initially the signs and symptoms referable to somatotrophs, lactotrophs, and gonadotrophs. For example, if there's a pituitary mass over there, the usual presentation is galactorrhea or infertility. Then, if you already have symptoms referable to the thyroid or corticotrophs, it means that the tumor is relatively big in order to affect the central portion of the pituitary gland. So that is the importance of knowing this chart. Again, what is the function of the pituitary gland? It is the master gland. Being the master gland, it orchestrates the formation, differentiation of peripheral hormones. There are six hormones. It comes from the anterior pituitary gland, and it also stores two other hormones in the posterior lobe. For the anterior lobe, the prolactin, growth hormone, thyroid stimulating hormone, luteinizing hormone, follicle stimulating hormone, and adrenocorticotropic hormone. And from the posterior pituitary gland, antidiuretic hormone and oxytocin are stored in vesicles and are secreted when needed. They are regulate they are regulated by hormones from the hypothalamus and trophic hormones, and in turn, they regulate the function of three other peripheral glands, the thyroid gland, the adrenal gland, and the gonads. The hypothalamus, the pituitary gland, and the peripheral organs function as a unit, and this is where the negative feedback mechanism works. These following hormones are the hypophysiotrophic hormones. This comes from your hypothalamus and the pituitary hormones. You can see that GnRH or gonadotropin releasing hormone stimulates two hormones in the pituitary, the luteinizing hormone and the follicle stimulating hormone. The corticotropin releasing hormone stimulates adrenocorticotropic hormone, ACTH. The thyroid releasing hormone stimulates thyroid stimulating hormone. The growth hormone releasing hormone and the growth hormone releasing inhibitory factor acts on growth hormone, but mainly the action of the hypothalamus on growth hormone is stimulatory through growth hormone releasing hormone. The only exception here is prolactin because the main function or action of the hypothalamus on prolactin is inhibitory. which is a prolactin release inhibitory factor, which is or inhibitory hormone, which is also dopamine. There is also a prolactin release hormone, but the action is mostly the mainly prolactin release inhibitory hormone for prolactin. So that is the only exception to this rule. This is how the hypothalamic pituitary thyroid axis works. This is a repetition of what I said a while ago. So the hypothalamus and pituitary gland responds to the concentration of the peripheral hormones. An example of this is the hypothalamic pituitary thyroid axis. For example, if the thyroid hormone levels are normal in the periphery, then the pituitary and the hypothalamus are also normal. But if the thyroid hormone levels are elevated, then they send this signal to the anterior pituitary gland and to the hypothalamus, and this is sensed by both organs, and therefore the end effect is to decrease the stimulation to the thyroid gland in order for balance to be restored. In the same way, if hypothalamus or if the thyroid gland or if the thyroid hormones are low in the periphery, then this signal will be sent to the pituitary and hypothalamus, leading again to a stimulatory response by the pituitary and the hypothalamus in order to increase the concentration of T3 and T4 in the periphery. This not only happens in the thyroid, but it also happens to other peripheral hormones like the adrenal glands, the bones, okay, so gonads. So this is how the negative feedback mechanism works. If you have a problem in the thyroid or in the periphery, it is called a primary problem. If you have a problem in the anterior pituitary, it is called a secondary problem. And if you have a problem in the hypothalamus, it is called a tertiary problem. So the challenge to each and every clinician is to know where the problem is. If you have a hyperfunction, a hypofunction problem, or a receptor problem, the challenge is to look for where the problem is. Is it a problem? Is a problem a primary problem? Is it in the periphery? Is a problem secondary? Is it in the adrenal anterior pituitary? Or is a problem tertiary? Is it in the hypothalamus? And therein lies the beauty of endocrinology, because you are like you have to discover where the problem is. Again, as I said, it also occurs in other parts of the body. So you have the liver for growth hormone, you have the bones for again growth hormone, you have the breast for prolactin, and you have the ovaries, estrogen, progesterone, and you have testosterone, and of course thyroid and steroid hormones. So we now proceed to the diseases of the anterior pituitary gland. Do you know who has a problem here? Is it the Lola? Is it the one in front with a headband? Is it the little girl, or is it the other lady? Who do you think has a problem here? Okay, you put your guesses in your mind. Let's proceed. Who do you think has a problem here? Is it the small guy or is it the tall guy? Again, I leave you to your choices. Put these choices in your mind. Is this problem abnormal or is it not abnormal? Is this man is pregnant or is he just fat? How about this guy? Is this guy pregnant? Is this guy pregnant or is he just fat? Do you think you're looking at yourself? Because I think I'm looking at myself. Do you think this is a guy or a woman? And here, do you think these patients have problems? Pituitary problems usually are very blatant. abnormal, or you may be walking in the streets, not knowing that the one next to you is having problem in the pituitary gland. These two patients, both of them have pituitary problems. And again, as I said, the challenge is to know where the problem is. Is it due to cellular mass, hormone deficiency, or hormone excess? These patients have prolactinoma. They have problems in prolactin excess. Hyperprolactinemia. For the her presentation is headache, and for the other, her presentation is blurring vision. And both of these patients were referred to me by ophthalmologists and neurologists, where CT scan was done, revealing a mass, and investigation revealed prolactinoma. This patient is just obese. He has no hormonal problem. But obesity is actually hypercortisolism, but does not reach the levels of Cushing syndrome. This is Cushing syndrome. This patient has elevated cortisol levels, and he was worked up, revealing an adrenal mass. You can see the striae here is more than 1 centimeter, very violaceous. And you can also note the thin extremities as compared with the central part, which is enlarged. And you also can note the striae in the armpits compared to this patient, wherein the striae is only very light, even if he has some form of breast enlargement. And please note the neck, that is what we call acanthosis nigricans, which is blackish discoloration of the neck, which is a sign of hyperinsulinism. These two patients belong to the Guinness World Book of Records for the tallest and the smallest guys. The tall one has a problem with a the pituitary gland, leading to an increase in GnRH, leading to a tall stature. And the small guy, short stature, has a problem in the receptors, leading to that uh, small patient. And here is a problem of hormone deficiency. The girl with the headband has hypothyroidism. But if you compare each and every one of them, they almost look the same. Again, as I said, you might see a patient who is really different from the others, but it can also be a normal patient having a hormonal problem. So you really cannot identify. But if it is like this, you really need to work up these patients. If it is like this, you really need to do an endocrine test for these patients. But here, you really need to do an endocrine test because you want to know whether this patient has an endocrine problem or not. You have to differentiate normal from abnormal in order for you to know if you need to give any hormonal tests or hormone management, and as well as for these patients. Again, the diseases of the pituitary gland may be due to hormone excess, hormone deficiency, or due to cellular masses. We first go to hypopituitarism. When we say hypopituitarism, it is a decrease in the secretion of one or more of the pituitary hormones. The classification may be complete, partial, or isolated. For complete or pan-hypopituitarism, it is a deficiency of all anterior pituitary hormones. For partial hypopituitarism, it is a deficiency of only some of the pituitary hormones. But in isolated hypopituitarism, the deficiency is only in one pituitary hormone. And this may be due to a lot of causes. It may be due to a developmental or genetic cause like pituitary dysplasia, which may result from a plastic or hypoplastic ectopic pituitary gland, that leads to that comes from the problem in the development from the Rathke's pouch in the midline migration of that ectoderm. And may also be acquired. For example, for you who have wives, sisters, parents, very important. There shouldn't be any failure in birth because it may lead to pituitary failure if there is a birth trauma, cranial hemorrhage, asphyxia, or even breech delivery can lead to an acquired pituitary failure in the newborn. It may be due to developmental causes, like for example, pituitary dysplasia. When you say septo-optic dysplasia, it may be lead to hypothalamic or hypothalamic dysfunction and hypopituitarism. There may be dysgenesis of the septum pellucidum or the corpus callosum, and this is due to the mutation of the HESX1 gene, which is involved in the development of the ventral prosencephalon. And what is the presentation of this subtle optic dysplasia? Left palate, syndactyly, ear deformities, hypertelorism, optic atrophy, micropenis, and anosmia. And the pituitary deficiency leads to diabetes insipidus or growth hormone deficiency. They may present as short stature and occasionally TSH deficiency leading to hypothyroidism. Hypopituitarism may be also due to a developmental hypothalamic dysfunction. For example, in Kalman syndrome, in the Lawrence-Moon-Bardet-Biedl syndrome, or in the leptin receptor mutations. All of the Lawrence-Moon-Bardet-Biedl syndrome and leptin receptor mutations lead to obesity. Aside from obesity, in the Lawrence-Moon-Bardet-Biedl syndrome, you have mental retardation. Also, you have brachydactyly, hexadactyly, or syndactyly. Brachydactyly meaning you have an extra finger. Instead of five, you may have six. You have renal abnormalities, diabetes insipidus, GnRH deficiency, and retinal detachment. And in Kalman syndrome, which is more common, you have a defective GnRH synthesis. And if you have a patient with hypo, low testosterone, then anosmia, you can have the diagnosis of Kalman syndrome. So aside from anosmia, you may also have optic atrophy or nerve deafness. You may also have cleft palate, cryptorchidism, and this is due to the mutation of the cow gene. So in the Prader-Willi syndrome, it is contiguous gene syndrome development resulting from the loss of paternal copies of the SNRPN gene and the nectin gene and other genes on chromosome 15. It leads to hypogonadotrophic hypogonadism, hyperphagia, especially leading to obesity. But these patients cannot walk. They have chronic muscle hypotonia, mental retardation, and adult onset diabetes mellitus. We also have somatic defects involving the skull, the eyes, the ears, the hands, the feet, and of course, hormonal deficiencies include diabetes insipidus and GnRH deficiency. So both Prader-Willi syndrome, Lawrence-Moon-Bardet syndrome, leptin and leptin receptor mutations lead to obesity. The only difference is that here in Prader-Willi syndrome, the patients cannot walk. They have chronic muscle hypotonia and mental retardation. And in Moon-Bardet syndrome, they have brachy, hexadactyly, and other renal abnormalities. Again, the hypopituitarism may be acquired, may be due to a tumor in the pituitary gland, may be due to craniopharyngioma or meningioma, especially if you have a patient with craniopharyngioma. Usually, these are patients with short stature, high pitched voice, young patient. And